Welcome to the Beach RN, brought to you from the beautiful Mornington Peninsula in Victoria, Australia. Today we're looking at acute pulmonary edema, APO. Let's look at a global visualisation of the important anatomy. We'll bring up first the thorax with the heart that's central and slightly over to the left. It starts at the 4th intercostal space and the apex is at the 6th intercostal space. The lungs sit globally in the thorax, both anteriorly and posteriorly. That's useful when you're auscultating the chest to know some of the landmarks. You can see there are also the diaphragm. This is a lovely picture of the diaphragm and helps you understand why it's called the bellows. It comes down to aid active inspiration. You can see here the liver takes up a large component of the cavity too. Now, let's look at the chest with the heart and the lungs in it with my diagrams. I'll make that a little bit bigger for you. I've got the right side and the left side. There are 3 lobes on the right side and 2 on the left, and the heart. I'll simplify the heart by dividing it into 4 chambers. The inferior and superior vena cava empties deoxygenated blood into the right atrium, then into the right ventricle, where it goes to the pulmonary trunk to the lungs. Here, oxygenation occurs. Oxygenated blood then comes back via the 4 pulmonary veins to the left side of the heart. The left atria, then the left ventricles, which pumps oxygenated blood out to the body. APO can be caused by a number of conditions. The first one can be failure of the pump, for example, congestive heart failure, and this is due to failure of the left side of the heart. When right-sided heart failure occurs due to left-sided heart failure and subsequent pulmonary congestion, it's called cor pulmonale. Other causes can be arrhythmias, valve dysfunction, fluid overload, and altitude sickness. Now let's zoom in on APO pathophysiology. We have the bronchioles, and at the terminal ends we find our alveoli. They're supplied by arterioles and venues with capillaries in the middle. Let's look at one of those alveoli sacs. You can see the blood supply hugs closely to the alveolar epithelial surface, and in there we have carbon dioxide drop off, which we then breathe off, and oxygen is transferred across into the bloodstream. If there's congestion, then we have fluid moving into the alveoli, so the patient will show signs of dyspnea, orthopnea, that is the ability to breathe only in the upright position. Upon auscultation of the chest, you can hear crackles. That can sound like rice bubbles having milk added to them. Capillary return over 3 seconds if there's problems oxygenating, and cyanosis may also be present. And worryingly, SpO2, oxygen saturation, can be less than 94%. We'll now move on to APO and its initial treatment. We'll focus here on cardiogenic pulmonary edema, like the failure of the pump. Initial management nowadays can be sublingual GTN, 300 to 600 micrograms every 5 minutes, and be aware that's if the BP is greater than 100 to 110 systolic. Of course, this depends where you work and the policies and procedures there. If it's the first time the patient is having GTN, we're looking at giving 300 micrograms. We don't want to seriously drop their blood pressure. Also useful in the treatment of APO when we want to get fluid out of the alveoli sacs is the use of CPAP or BiPAP. And we're essentially trying to do 2 things. If we look at the heart and the lungs as simply a pumping system, then we're trying to move fluid around and oxygen in. The problem with APO is we've got a reservoir in the pump, and then out of that is a narrowed lumen with respect to the patient's arteries. There is thus high blood pressure for the pump to pump against, caused by narrowing of the arteries due to, for example, a buildup of atherosclerosis and stress. With the narrowed lumens, there is a building up of pressure back in the pump, which starts at the left side of the heart. Don't forget, we also have fluid coming in from our inferior and superior vena cavas. So we've got fluid continuously coming in, being pumped to the lungs. Problem is, it's not getting out enough through the left side of the heart. So we get a buildup of pressure of fluid in the lungs, which then causes the fluid component of the blood to seep into the alveoli. We now have acute pulmonary edema. The sublingual GTN helps open up what we call the afterload that the left ventricle has to pump against. So we are effectively opening up the lumen, relieving the pressure in the left side of the heart, and the patient is able to get some of the fluid out of the alveoli and back into the bloodstream. Also, by causing vasodilation, we're having less fluid come back into the right side of the heart. That's called our preload. But we're mainly interested here in our afterload. Well, I hope that's helped you today with understanding APO. This has been brought to you by The Beach RN, education for registered and student nurses.